But I think Dr. Alok has made my job not only easier, but also smoother to take it forward. And just to prove the point about awake spine surgery and the apprehensions there, I'd just like to bring forward some orthopedic cases that we all see in day-to-day practice. We have all evolved as orthopedicians, doing neck femurs, femur fractures, and TKRs are happening in day-to-day. All orthopedic lower limb surgeries happen in anesthesia, which we as surgeons rarely bother to decide upon. And we have come into such a comfort zone that we take no part in decision making about what kind of anesthesia is required or suitable for the patient. How many of us actually tell our anesthetist or decide that we want this particular kind of anesthesia? I can vouch that it is less than 1% people. And 99% people live in the comfort zone that I don't bother what anesthesia comes across because I am an orthopedician or I am an XYZ surgeon and I would do the surgery and I'll go away. And same comfort zone has been extended from orthopedic surgery into spine surgery because we evolved from orthopedics to spine, that we don't take care in decision making about what anesthesia is required, irrespective of the pros and cons, because probably we consider that that is not our forte, that is not our field to decide upon, that is not our field to venture upon. And this comfort zone of the orthopedicians has percolated into a blanket understanding that general anesthesia is the only and the safest way to do a spine surgery for all lumbar cases. Today, this paradigm and this comfort zone, this paradox is to be broken because awake spine surgery is a reality. It is safe and gives far more benefits than any general anesthesia related spine surgery. The only thing is to come out of the box of the comforts and start taking part in decision making about what kind of anesthesia you want for your patients. Awake spine surgery is not something heavy technology involved into this. And it has got amazing results, and more so in minimal invasive spine surgery. It just means doing spine surgery without general anesthesia in a fully conscious patient using various kinds of regional anesthesias. It can be a spinal anesthesia, it can be a combined spinal epidural anesthesia, it can be associated plus minus with erector spinae block or TLIP blocks, like Dr. Alok Sharan, previous speaker, mentioned. And believe me, just this kind of anesthesia can take care of all the surgeries from L2 downwards to sacrum, pelvic, lumbosacral fixations, MIS, TLIP, decompressions, lumbar laminectomies, lumbar decompressions for LCS, facet cyst, disc, anything in lumbar spine. You can do this with extreme safety. And I'll show some cases to this. So the biggest question is, has it come now? Is it new? The spine surgery under awake spine anesthesia has shown wonderful results for decades. And there are phenomenal number of literature articles into it. You can see just a 0.5 seconds and you see 25 lakh results into it in Google. And there is wide range of literature into it. Now it has got a resurgence because of the early recovery after spine surgery protocols, ERAS protocols. Yesterday also I highlighted that we have been focusing so much on technique that we forget that the ultimate outcome is early recovery, and minimal invasive spine surgery is only a point focus of it, and it has a lot of other things to ensure early recovery of the patients, to which comprehensive anesthesia protocols and avoidance of opioids is something very, very important to ensure early recovery of the patients. And comprehensive anesthesia protocols involve use of minimal invasive anesthesia protocols also. So why do we recommend awake spine surgery? Because it has advantages beyond comparison. There is nothing that you should hold you from thinking about these advantages. Post-GA delirium, which is the most fearsome and gruesome problem that patients remember after the surgery, is just not seen in spinal anesthesia or in renal anesthesia. There is no nausea, no vomiting, no post-operative hallucinations after awake spine surgery, and that's why these patients have a very pleasant post-operative care, requiring no analgesics, no antiemetics, no any medications, and absolutely minimal monitoring post-operatively, reducing the nursing burden. Operative time, initial days you may find it longer, but as you grow, evolve, you find that the overall operative time has also come down. You don't need any time for extubation and post-operative medication. The hemodynamic stability is beyond comparison. And because the medication required in general anesthesia is absolutely vanished in renal anesthesia or in spinal anesthesia, in awake spine surgery, the cost-benefit analysis is far in favor of renal and awake spine surgery. Like Dr. Alok mentioned, that most of these patients, when you talk to them and counsel them that GA is not even required, patient satisfaction and acceptance is also very, very high compared to when it comes to general anesthesia. And that leads to an increased volume of the surgeon also. Of course, that's not the reason you should take up, but that is one added advantage that your practice also may boom up because patients accept it better. So then why is it not widespread? I think the biggest reason that spinal anesthesia or regional anesthesia in spine surgery is not widespread is because of the lack of surgeons' belief into it. And that has led into anesthesiologist preference for general anesthesia and also has percolated into decreased patient acceptance. Of course, the unpredictable length of the surgery and some obvious contraindications should be taken into consideration when you choose awake spine surgery. But the three things that you have to break down is the surgeon's belief. Patient acceptance will increase if the anesthesiologist also starts understanding, and this only requires a communication with the whole team. So what all can you do? You can do everything. You can do a disc, you can do a facet cyst, you can do a lumbar canal stenosis, you can do a facet arthritis, you can do single level fusions, you can do listhesis, you can do 2 level, 3 level fusions, sacropelvic fixations. Also, we have done in our practice just by combined spinal epidural anesthesia. Any surgery which lasts less than 4 hours can actually be done by a awake spine surgery because that's the duration from incision to closure that this thing will work. The best part is that the analgesia part lasts for a longer duration. The anesthesia part may actually last for 4 to 6 hours, but the analgesia lasts for almost 12 hours. So post-operatively also, when the patient is in the ward, you may not receive calls that the patient is in pain or in discomfort situation requiring absolutely nil post-operative analgesia. Of course, there are obvious contraindications, big fat belly, a reduced cardiopulmonary reserve. I would refrain myself from using this kind of anesthesia. But we do deal with these situations and we talk to our anesthetists and decide upon, take role in decision making about the type of anesthesia. And it has proven wonders in orthopedic, abdominal and pelvic surgeries in the last more than 2 decades. So why not spine surgery? We have done 1,000+ cases in last 4 years, and the patient selection being the key has led to enhanced patient satisfaction. What it needs is only protocols which are not only surgery related but also comprehensive anesthesia related, which start right from pre-operative counseling and consent taking to intra-operative management and post-operative counseling and communications. Let's take this one by one. So what is the pre-op protocol? Consent that we will be giving a spinal anesthesia, regional anesthesia, but if it requires, we might have to convert into general anesthesia also. If the surgery lasts longer, we might convert it. So information to the patient is taken. Communication to the whole team, including the staff, the nurses, so that the OT noise goes down and there is no chaos in the OT when this is happening around. In females in particular, they are awake. So keeping a nurse all the times, right from pre-operative to intra-operative or post-operative, it's very, very important to keep them very comfortable, particularly females when they are naked and awake spine surgery happening in prone position. Hydration is done in these patients, and of course, giving high dose proteins 3 days in prior, and also pain management with acetaminophen is done a day prior. It's a standard spinal needle. A thinnest possible needle is used in the higher levels in L3, 4, and we use a standard molecules for giving regional anesthesia. And T-lip block is given in patients when we have anticipated longer surgery. OT is the most important place where protocols have to be laid down. A female staff or nurse should accompany a patient, particularly when it's a female patient. There has to be zero communication between the staff, which is not possible. So to reduce the noise, we generally give noise cancellation speakers and an iPad or a phone or a music system to the patient to just keep himself entertained all the time when the patient is lying prone there. The communication in the OT team has to happen with gestures. And if there is an instrument missing, if you are going to hammer, this has to be informed to the patient well in advance. And this communication plays a very important role to reduce the apprehensions and increase the acceptability of these patients. There has to be a viewing screen so that patient remains entertained, and patient is told that if there is any discomfort, just raise the hand and one of our team member. So they have to be made most comfortable, and that enhances their satisfaction rate and reduces the apprehension, increases the acceptance, and also post-operative satisfaction about this particular kind of anesthesia. Nursing staff is told about it very well in advance about the post-operative protocols also. There is no need of analgesics, there is no need of antiemetics, there is no need of any medication unless patient really asks for it. Urinary bladder is drained once if the patient doesn't have in 12 hours, but usually most of the patients just walk within 6 to 8 hours and they can walk to the washroom for draining themselves out. Early mobilization is key to the early recovery protocols, and after spinal anesthesia is over, which happens in 6 hours, patients actually can be mobilized the same day. And indications are wide. Some case examples, lumbar canal stenosis or a TLIF, like in this particular case, L4-5 TLIF was done, a minimal invasive TLIF was done, and 70 ml blood loss, 2 hours surgery, patient walks home the same day. Another patient with lumbar canal stenosis, we just did a microscopic tubular decompression under spinal anesthesia, just an hour surgery, and very predictable outcome in these patients, again in spinal anesthesia. This has led to a combination of miss and awake spine surgery protocols, resulting and giving us wings to set up a daycare spine surgery unit where patients come at 6 o'clock in the morning, receive these protocols. They have been communicated very well in advance. All the protocols, pre-op protocols are done with, and they come same day, get surgery done. By 4 o'clock, they're walking around and they have the liberty. We don't send them away. We are not trained to send them the same day, but they have the liberty to walk home after dinner the same day. And these decompressions particularly give wonderful results. Not only are they very satisfied, their acceptance level and referral levels also increases. Is age a contraindication? Absolutely not. You can do this in 90-year-old gentlemen also. If you can do a DHS in a 90-year-old lady or a male, you can do the spine surgery also, provided there are no medical contraindications or very high BMI or a COPD, where I would refrain from putting a awake spine surgery in these patients. And as I mentioned, the advantages are phenomenal. These patients have absolutely no qualms. After the surgery, they are so comfortable, and the monitoring and the burden on the nursing system is absolutely minimal. You really don't have to be worried about monitoring these patients. Their hemodynamic stability is wonderful compared to the general anesthesia. And benefits are obvious. Yes, there are problems also we have seen, but they are minimal. We have worked extensively and published extensively our work in awake spinal surgery, and that is the future of it. When combined with minimal invasive spine surgery protocols and early recovery after spine surgery protocols, I think awake spine surgery is the future of it. How to set up the unit? I think the one thing is just come out of the comfort zones. Start talking about it. Start playing roles in deciding about what anesthesia you want. Follow the ASS protocols very stringently, right? From pre-operative to intraoperative to post-operative. And communication is the key, both with the team, the nursing staff, and the patient. And all this can be done pre-operatively. We actually have hired a nurse who just does the communication part about the awake spine surgery. And these protocols have now given us wonderful results there. Sometimes we do find that dural puncture, the needle puncture there. But is that a problem? No. 99, not 100% of these cases, there will be a blood patch that will seal it off. And we have not seen a single case of CSF leak after these kind of awake spine surgery protocol. Yes, one of our patient had a vasovagal syncope. We had to convert it into general anesthesia, but that's something that can happen anytime with any other case as well. There is no risk of post-operative headache. There is never been a chance of hypotension post-operatively requiring any kind of ICU turnover, and there is absolutely no need to convert them into any GA for any other reason there.
Vishal, sorry, your time is
I'm just finished up there. So the future of this is, as we get liposomal bupivacaine, prolonged surgeries will be done. We can actually do 6 to 8 hour surgeries. This molecule is still not available, but I think a combination of these with selective molecules available, even thoracic surgeries will be possible, enhancing wings for tuberculosis, trauma, and other thoracolumbar pathologies there. So with this, awake spine surgery under regional anesthesia is the future of it. It is just that we have to come out of it and start adapting it. And the reproducibility is very high. Even in rural setups, you can actually do it. The key of success to awake spine surgery is patient selection and operative protocols, which should be laid down stringently. Thank you, gentlemen. Thank you, Chair.